is the
okay.
vice chair for education. So it's the two of us that are able to go.
Here or in Colorado?
No, here, Family Medicine. I'm hoping. We've got to get care set for my husband. That's the big thing. My husband, who takes opioids for chronic pain, we can't find anyone to prescribe. It's so ironic with what I do, but
Yeah.
Ironies abound.
I know. I get sometimes give these talks and get on my soapbox about, we've gone totally the other way and people won't prescribe anymore. And yeah.
You're going back Wednesday.
Yeah, well, Tuesday night, yeah.
Because next Wednesday, Psych Grand Rounds is being done by a pain person here in
Oh, shoot.
Mateo Caffrey.
Yeah.
You know Mateo?
Uh-huh. Oh, too bad. I would like to hear that. It should be recorded, yes? It'll be recorded, yes?
I don't know.
I'll have to find out.
I don't think in the past they've recorded them, but they're obviously recording.
They are today.
Yeah. Well, they may all be now.
Okay. Find out. Geez, people are still wandering in.
There they are. The students are just in touch.
Must have gotten publicized through the hospital.
There is that. Good morning.
Are you our speaker?
Yes.
Okay, I'm Susie Azazi. I'm the chief resident. I'm going to be doing your introduction.
Nice to meet you.
Nice to meet you. Thank you for coming
Sure,
today.
absolutely.
Are you ready to get started?
I'm ready whenever.
Yeah,
That's
I
fine.
think people will trickle in late because they're coming from their clinical sites.
That's
but
fine.
I usually have a microphone. Do they have a microphone for you?
Yeah.
Okay, good.
I have it hooked already, so just yell.
Yeah, project. Okay. Good morning and welcome to Psychiatry Grand Rounds. The Grand Rounds Committee requests that you silence your cell phones and refrain from unnecessary use during the presentation. If you are a resident, medical student, or an attending who likes to register for CME credit or attendance, the call-in system is posted at the back of the room, the new attendance system. This morning I have the pleasure of introducing Dr. Beth Bailey. Dr. Bailey obtained her Bachelor's of Science in Clinical Community Psychology at University of Michigan in Ann Arbor and a Master's and PhD in Developmental Psychology at Wayne State University in Detroit, Michigan. She is currently the Director in a Division of Research in the Department of Family Medicine at the College of Medicine at East Tennessee State University, as well as a tenured professor in the Department of Family Medicine. She also serves as the Vice Chair for Research for the Department of Family Medicine, and she is a senior graduate faculty member in the Division of Graduate Studies at East Tennessee State University. She also holds the title of Visiting Professor in the Division of Maternal Fetal Medicine in the Department of OBGYN in the University of Colorado. Please welcome Dr. Bailey.
All right, good morning. I'm going to make sure I follow the rules and silence my phone too here. All right, well, thank you all for being here. I'm excited to talk today about a topic that's been pretty hot and people are very interested in hearing about. If this is your field or you're an expert in this area, this is going to be pretty basic, so it will be mostly review for anybody who regards this kind of as their specialty. But really what my goal was to try to talk to you about kind of what the opioid epidemic is, kind of how we got here, what some of the statistics are. We see that term thrown around a lot in the popular media. And so I want to give you some information, kind of some background of what that means, how we got to this point and where things are going in terms of trends and the kind of the epidemiology of it all. All right, my disclosure, no conflicts of interest, financial or otherwise. All right, so here's the overview. As I said, we're going to try to keep this kind of focused on the trends and the data that's out there. Want to talk a little bit about adults versus adolescents, because that's an important distinction. Also talk about a particular specialty population, pregnant women. And then talk a little bit about the opioid use and exposure, the implications of it all, and then try to summarize it for you. All right, so what I thought I would do, this is kind of, a lot of these slides are very dense, there's a lot of numbers, so I want to keep you awake here with some questions, get you thinking a little bit. So I want to start out with a question here, which is how many people die from a prescription opioid overdose every day in the United States? Let you think about that, ponder that. Okay, anybody want to be bold and give me an answer?
I'll guess C. C for 1,000, Alex.
Okay, perfect. C, 95. Take a guess. Anybody else? All right, well, I'm going to pose questions and then I'm going to give you answers with the data. So here we go. All right, so this is just a brief snapshot to start our discussion today about some of the data that's out there about opioid use and abuse. The numbers on each of these slides refer to references, so if you're interested in the actual references that accompany this presentation, just let me know. I'd be happy to email those to you. All right, so to start out, every day more than 115 Americans die after overdosing on opioids. So the answer was actually D. That is a total of about 33,000 in 2015. Okay, drug overdoses are now the leading cause of injury death in the U.S., has passed motor vehicle accidents and other causes of death. From 2000 to 2015, so over that 15-year period, we've seen drug poisoning deaths contribute a loss of about a quarter year of life expectancy population-wide. So when we talk about markers and things that cause people to die, we often look at how many years of life expectancy are lost. When you look at that, that's just amazing. We lose 3 months population-wide because of deaths due to drug overdose. A couple years ago in 2015, an estimated 2 million people in the United States suffered from substance use disorders related to prescription opioid pain relievers. 2 million people. Okay, we also have about 250,000 adolescents that are current non-medical users of prescription pain relievers. 250,000. And then we have about half of those which have been found to have an addiction to those pain relievers. Okay, and then finally looking at the total economic burden of prescription opioid misuse in the United States, it exceeds $78 billion annually. So this includes not only healthcare costs, but losses of productivity, okay, anything that goes along with that opioid use, even criminal justice involvement. All right, so prior to 20 to 30 years ago, the most commonly abused drugs were illicit. So when I started my career in drug abuse research, we were typically talking about things like marijuana. We still are talking about marijuana. But cocaine, heroin, methamphetamine, LSD, these were the things that when we did drug abuse research or dealt with it in a clinical setting, these were the drugs that we were typically encountering. So abuse, at that time, abuse of prescription drugs was much more minimal, largely involved stimulants and to a lesser extent depressants. So we had amphetamines, we had barbiturates that were the drugs that were abused if someone was abusing prescriptions. All right, so prescription opioids have been around for a while. They existed in the 1970s, branded hydrocodone type of drugs. Most physicians viewed them as addictive and didn't routinely prescribe them. So, when we go back 40, 50 years, there was really this hesitation when these drugs came onto the market and were available for outpatient prescribing that physicians wouldn't prescribe them. There was this definite fear that they could be addictive. However, in 1980, there was a letter that was published in the New England Journal of Medicine. And this letter led to a lot of changes in thinking. So what it was it described an analysis of over 11,000 patients who were treated with narcotics, and the conclusion of this letter was that the development of addiction is rare in medical patients with no history of addiction. All right, so this was published in the New England Journal. Physicians read this, and they said, oh, maybe it is okay to prescribe these narcotics for pain. That our patients aren't going to become addicted. And so we started to see throughout the 80s and into the early 90s a shift in thinking and practice about it being much more acceptable to prescribe these prescriptions, these narcotics. All right, another question for you. What percentage of patients prescribed opioids will misuse them? Okay, so if you subscribe to the theory that published in the New England Journal letter, okay, we'd probably be at less than 1%, but what do you think the reality is? Anybody want to guess? Anybody? D. Okay, we'll go for the highest one, right? 45. All right, so let's look at the data. All right, mid-1990s, the American Pain Society pushed for pain as the 5th vital sign. So many of you have probably heard that pain was considered a vital sign. We needed to assess it. We needed to treat it as much as we do anything else. All right, in 1996, we had a big change. A brand name oxycodone, which I will not mention by name, came onto the market and was really strongly marketed. It was really pushed with physicians, with patients, pushed as being safe. And in 2001, the Joint Commission affirmed what the APS had been saying. They affirmed what a lot of the drug manufacturers were saying and said that pain should be assessed and treated in all patients. And they actually published some literature citing studies claiming there's no evidence that addiction is a significant issue when persons are given opioids for pain control. Okay, so it's the Joint Commission less than 20 years ago. All right, prescription of opioids became widespread in the mid-2000s as a result of some of these publications and some of these changes. All right, unfortunately though, as it turns out, Porter and Jick were wrong. Okay, so their data that were published, remember it was a letter, it was not a well-controlled peer-reviewed study. Many of the findings were anecdotal. And so unfortunately, as many as 30% of patients prescribed opioids for chronic pain will misuse them. So the answer on the last slide was C. Okay, as many as 12% will develop an opioid use disorder, so more than 1 in 10 are actually going to develop substance use disorder. We have seen as people are legitimately prescribed opioids, they get diverted at very high rates. And we've seen an increase in doctor shopping and drug-seeking patients as prescriptions for opioids have grown. All right. So we've had a lot of studies that have come out since the Porter and Jick report, and once people started prescribing very heavily, started receiving these drugs, and most of these studies have shown the addictive potential of these prescription opioids. Okay, there was a 2006 study, which I think was very interesting, that found that measuring pain as the 5th vital sign actually does not improve pain management. So even when we put it in there and we make sure that it is being assessed and being addressed, the outcomes of that study showed it really doesn't improve pain management. So in 2009, the Joint Commission reversed its position from 8 years earlier and discontinued the recommendation of looking at pain as a vital sign. We've seen prescription drug monitoring system implemented in dozens of states so that when someone goes and gets a prescription for an opioid, that's registered in a state system. So that will, the idea is that will hopefully minimize doctor shopping, abuse of prescriptions from multiple providers. And a lot of these now are starting to communicate even across state lines. We've seen changes in medical education, warning providers of the dangers of opioids, and there have been a lot of recommendations about what it means to responsibly prescribe opioids. Okay. Unfortunately though, despite all of these steps, we really have not seen the tide stemmed yet. So we see opioid overdoses have increased 30% in many states just in the last, well, there's a period here that ends a little less than a year ago, but over a year period very recently. So we are still seeing increases in opioid use and abuse. Midwest has been particularly hit. They were kind of slow as the crisis started, and we see big increases there right now. And then opioid overdoses in large cities have increased over 50% in 16 states just in that 1 year period. All right, so how about this? What percentage of people who use heroin first abuse prescription opioids? Guesses? I'll let you think about it for a minute. All right, I'll move on, keep it in mind. All right, so as we've kind of seen this backswing, as providers are becoming educated about responsible prescribing, as the prescription drug monitoring systems have come into place, as we have seen professional organizations kind of get away from this treatment of pain with narcotics, we've seen some issues. So one of the big issues that we see is people who legitimately need prescription opioids now have significant trouble getting them. And there's a literature on this, and I won't get into this here, but many organizations have banned prescribing altogether, trying to figure out what does responsible prescribing mean, and finding out that's just too difficult to figure out and doing away with prescribing altogether. But the people who really need them, it's led to significant decreased quality of life, and even we've seen a spike in suicides among chronic pain patients who've had their opioids cut off. Okay, increased abuse of easier to get and more dangerous prescription narcotics and illicit opioids. So if you can't get the hydrocodone that you were getting, okay, you've got to figure out something else if you have an addiction and you're not getting treatment. So what do? You turn to other drugs, prescription narcotics that are easier to get, or you turn to illicit opioids. Okay, so an estimated 4 to 6% of people who misuse prescription opioids transition to heroin. But if you look at it on the flip side, about 80% of people who use heroin first misuse prescription opioids. Okay, so we're very much seeing a transition into illicit drugs from people who can no longer get or easily get those prescription narcotics. All right, we've also seen significant increases in abuse of and deaths from fentanyl. Okay, so this is another prescription opioid that is much more toxic, can be much more harmful, but is apparently easier to get right now. All right, so let's take a look here at some of the statistics. So nationally, this is a survey that, we'll mention this survey several times here, that was put out by the Substance Abuse and Mental Health Services Administration, which is a branch of the Department of Health and Human Services. And they do a survey every year and look at drug use and drug use trends. These are results from the 2016 National Survey. And as you can see, the self-reported abuse of prescription opioids for all age groups in the past year, 4.3%. Pretty high. Okay. When we look at it by age groups, look at the 18 to 25-year-olds, much higher rate than any of the other age groups. Okay. So this seems to be our group that is abusing prescription opioids the most. So almost 2% report use in the past month. 1 in 50 18 to 25-year-olds. All right, so if we look at self-reported opioid use disorder, so not just did you use them, but have you actually been diagnosed with a substance use disorder as a result of using them? Okay, we see obviously the rates are much lower and probably underrepresent the people who actually do have a substance use disorder, okay, either because they haven't gotten medical treatment and haven't been diagnosed, or they're underreporting. But again, we've got those 18 to 25-year-olds, almost 1% of them have been reported to have a substance use disorder as a result of their opioid use. All right, another question for you. Which age group has the highest prescription opioid overdose death rate? All right, so you're going to want to tell me 18 to 24, right? Based on the numbers that I just gave you. Okay. All right, in fact, that is not the case. All right, so this shows heroin and non-heroin opioid death rates. So the non-heroin is the darker bar per 100,000 people by age in 2015. Look at who's got the highest death rates as a result of opioid use. It is actually the older adults, 35 to 45-year-olds, and especially the 45 to 54-year-olds. So what does that mean? So are these people in this age group underreporting their actual use when asked if they're using? But when we go to vital statistics and look at death rates, which are obviously not self-report, are we seeing that they are actually using at a higher rate, or are they using at a level or in a way that is more likely to lead to death? And we don't really know the answer to that yet. All right, some other information, and again, I show these death rates because these are a bit more objective than the self-report, and it tends to be the data that we use over time, overdose deaths, and looking at how they're increasing. So this shows the trend from 2000 to 2015, and again, you've got heroin there on the bottom, and we've got non-heroin opioids on the top. All right, so take a look there. We've seen kind of a steady increase in the prescription, the top line there. And then we had a little bit of a sag from 2011 to 2013. So that's when the kind of that backswing happened, and we really were clamping down on prescribing. The prescription drug monitoring systems came into place. But people figured out how to get their drugs after that. And so then you see a really high rate of increase in the use of those drugs. All right, and look at heroin, the line on the bottom. So at the time it became very hard to get the prescription drugs, look what happened to heroin use. It went up. Okay, so we're really seeing these two things kind of go together, especially as the prescription opioids get harder to get. All right, so let's look specifically at these adolescents. So I showed you that the 12 to 17-year-olds on the last couple slides here. This is actually data from a survey called Monitoring the Future. It's done every year by the University of Michigan, and it surveys 8th graders, 10th graders, and 12th graders over a variety of things. Drugs is only one of them. Okay, now you will see here there's a lot of missing data in this table, and that is because the more detailed questions are asked of the 12th graders about the drugs. Okay, so you can see that when they are asked about any prescription narcotic, we have a lifetime use rate of 6.8% for those 12th graders. Obviously goes down past year and past month. But if you look across at some of these things, we see very interesting trends. So obviously the 12th graders have higher rates of use than do the 10th graders or the 8th graders. But we also have some interesting trends here, and I want to point out I have used the actual brand names here only because they used those actually in the survey. And so very interestingly, they actually asked specifically about those two drugs. And I think probably it leads to some underreporting, because somebody may take one of those, they may take oxycodone, but they may take a different brand name of the drug, or the same for the hydrocodone. So I think there was an attempt with this survey to make it kind of more real to life in terms of the names people might recognize, but I think probably it's leading to some underreporting. They're thinking that the respondents may think it only refers to that specific brand formulation. All right, so if you look there, we've got about 7% of 12th graders say that they have, at some point in their life, abused prescription opioids. Pretty high rate. All right, another question for you here. Among high school students, the rates of prescription opioid abuse over the last 5 years have decreased or increased? All right, so based on everything I've shown you so far, you would probably want to say increased, right? All right, but I'm asking the question for a reason, obviously, so let me show you this. All right, so this is also from the Monitoring the Future study. I do want to point out that they added those brand names, let's see if I can get this to work, right here. And so that's why there's a break in this line, because they had a real spike in reporting once they gave the actual brand names. Oh, yeah, I guess I do use that. So, you know, it kind of triggered that response for some of the people. So that's why the break in the line, and that's why these over here are only starting right here on the line. But as you can see, the use of both oxycodone and hydrocodone has gone down among adolescents over the past 5 years. Interesting. Okay, so perhaps we're doing something right when it comes to some of these targeted campaigns with adolescents, that they are getting the message that we're seeing use decrease. Could be a reporting issue, it's really hard to say, but at least on the surface, it's encouraging. All right, another question. Internationally, how does the U.S. currently rank in drug overdose deaths compared to other countries? Do we have the highest percentage of any country? Are we in the top quarter, in the middle, or in the bottom quarter? Overdose deaths related to prescription drugs. Anybody want to guess? You guys are quiet. A, want to say A? All right, unfortunately, A is the correct answer, and I apologize, this isn't super clear on this screen. So this shows that back in 2000, we were somewhere in the middle of the pack. Okay, so the U.S. is the red line there. in terms of overdose deaths related to prescriptions. However, you can see now we are way above the next country. Okay, and I also put up this other interesting fact on the screen here, that we are less than 5% of the world's population in the US, but we account for 80% of the consumption of opioid pain relievers. Okay, so it is no wonder that the chart looks like this. All right, another question. Let's drill down here and look at some local and regional data. How does Tennessee compare to other states in rates of past year opioid abuse for everyone aged 12 and older? Are we in the top fifth, the second fifth, third fifth, fourth fifth, or the very bottom? Guesses? All right, I hear rumblings of A and rumblings of B. All right. So we are actually in the second fifth when it comes to past year misuse of prescription drugs, opioids in particular. Let's see if I can get out here and do that. Okay, so we're right here, and if you look down here, that orange actually is the second fifth. There are other states that are higher, and look, you might think they might be here, but they're actually here. Okay, so we have seen beginning 2014, 2015 that the problem has really moved to the west. All right, however, when you look at that age group that is the most likely to use in the first place, the 18 to 25-year-olds, we're a bigger part of the problem. Okay, so Tennessee is actually in the top fifth when you look at 18 to 25-year-olds in terms of misuse of pain relievers in the last year. Okay. And interestingly, there are still some states in the west here, but we've got more states here in the southeast. All right, and then looking at drug overdose mortality, again, as I said, this tends to be the most used statistic. Obviously, it's much lower rates, it's much more extreme use of opioids, but because it's vital statistics, we tend to regard that data as a little more accurate. And when we look here, the Tennessee falls again in the top, or the second fifth, and we find that Tennessee actually has a rate of about 24. Let me make sure. I think it's 24.8. Yeah, 24.8. Okay, so we have 24.8 per 100,000 people deaths as a result of drug overdoses. All right, so Tennessee isn't as awful as you might think, but we're certainly up there. All right, so this is an interesting slide, an emerging trend here, and this is from the beginning of 2016 to the middle of 2017. So, and I would really like to see from the last 3 quarters here, once those data come out. So you saw the slide and that how the West seemed to be in trouble, also the Northeast at times. I drew an arrow here to the slide that represents the Southeast, and as you can see, the Southeast was kind of in the middle of the pack in 2016, but look at what's happened in that last bit of time here. So we have taken off in the Southeast, get over here, up here so that we're rivaling these other 2 regions. And there's been speculation about why this is, but nobody's exactly sure why it's gotten so much worse here in the last 18 months or so.
So is that deaths or is that simply overdoses?
This is overdoses. All right, so take a look at this. This is actually data by county. Oops, hang on. All right, and I know it's a little hard to see there, but these are overdose deaths, again, using those vital statistics. All right, so darker is worse if you can't read the part at the bottom here. And so look again, we've got this whole middle of the country that seems largely unaffected. Problems over here in the West, and problems certainly here in Tennessee and up in this region. Okay, so what these things really highlight is some of our rural counties. Okay, so if you drill down by county and take a look, the majority of these counties here that are in red are actually rural areas. Okay, so we're really seeing overdose deaths in our rural areas. All right, so let's look even more specific to our region. Which county in Northeast Tennessee has the highest rate of drug overdose deaths? Anybody? What did I hear over there? Carter, okay. Going on the trend of going a little more rural, right? All right, let's take a look. Okay, so this is a zoom in of that the graphic on the last slide. And if you take a look here, that first set of counties is the counties there in our region. It is actually Hawkins County that has the highest rate of overdose death rates. But look at Washington second, and not much further behind. Okay. And we have varying, but they're all in the 20s, unfortunately. All right, if you look down here, okay, these are other counties in the greater eastern area of Tennessee. Look at Campbell County. The rates are about twice what they are here right in our region. And I put the other ones that are higher than ours that are in the region there. Okay. If you look over here, these are our metropolitan counties in the state. So Shelby is Memphis, Davidson is Nashville, Montgomery is Clarksville, and Hamilton is Chattanooga. All of those are lower than all these rural counties. Okay. And then if you look here, these are our neighbor states that also have prescription opioid death rates that are high. And I put the counties in the Appalachian region in particular that were higher than ours. So the highest in the Appalachian region in North Carolina is Wilkes County. There are actually 2 coastal counties that have higher rates though. And then Martin, Kentucky, which is right in here, and McDowell, West Virginia, actually has the highest rate in the country, and that is right in here in southern West Virginia. All right, final note on these statistics before I move on to effects. The slide here is the one I just showed you. The one over here is actually prescribing rates of opioids. Okay? So looking at how frequently opioids are prescribed by providers. Look at how closely those line up. Okay? So prescribing has been a big part of the problem as we face this epidemic. You see the dark areas in this slide, the slide over to the right, line up pretty closely with the dark areas in the death slide. Okay? So those are rates of prescribing by providers of opioids. All right, so talking a little bit about a special population, pregnant women. This is more my area of expertise, but it's important to talk about because we have a population where someone using drugs is not just affecting themselves directly, but affecting the fetus as well. And the most recent data from this national survey show that over 5% of pregnant women in the U.S. will self-report non-medical use of prescription opioids in the last year. Okay, so that may or may not overlap with their pregnancy, usually it does. And about 1% actually report non-medical use of prescription opioids in the past month, so pretty high rate. Okay, rates are increasing. So in a study that looked at hospital discharge diagnostic codes, they found that antepartum maternal opioid abuse increased nearly 5-fold over a 10-year period. Okay, so these women are being discharged with a diagnosis code that includes opioid abuse. Okay, and just we have potential for effect on the fetus whether or not the drugs were prescribed, whether or not they're abused. So when we talk about pregnant women, we don't just talk about abuse, we talk about any prescription opioid use. Okay, and on these statistics here are quite alarming. We have about a quarter of women in a study that was done on Medicaid enrollees across 46 states, so pretty good national representation, found that a quarter of pregnant women filled an opioid prescription while they were pregnant. Okay, so these are being prescribed by doctors. These women are feeling like they are safe to use. Okay, and we have tens of thousands of women. I have been unable to find a good number for this yet, but tens of thousands of women every year receive methadone and buprenorphine to treat opioid withdrawal. Okay, so for any of you that are not familiar, when someone goes into treatment for opioid abuse, one of the mainstays of treatment is to give them replacement drugs called medication-assisted therapy. And so methadone has been the traditional drug used. We now have buprenorphine to complement that or to use in place of. And so these drugs will treat opioid withdrawal. Okay, the issue though for pregnant women is they are still damaging to the fetus. Okay, so they are opioid agonists or partial agonists, and they will lead to the same effects in the fetus. So we are concerned about the use of those drugs in pregnancy. Obviously, that's better than what they might have been using before, but we still have effects. All right, question number 9. What is the most frequent drug of abuse after tobacco among pregnant women in rural Tennessee? Is it marijuana, prescription opioids, methamphetamine, or alcohol? B. Well, since this is a talk about opioids, okay, B would be a logical choice. Okay, and in fact, you are right. All right, so 1 in 3 pregnant women in our region use at least one substance during pregnancy. That includes tobacco. Okay, so most commonly, obviously, we see tobacco, historically marijuana and alcohol, but more recently, we've seen a big surge in opioids, especially prescription narcotics. And so among rural pregnant women, prescription opioids are the most frequent drug of abuse behind only tobacco. Okay, it passed marijuana a couple years ago. All right, the best available state data for Tennessee that we have on rates of pregnancy opioid use actually come from the Tennessee NAS reporting system. How many people are familiar with that? A few. All right, I will give you a slide to show you what that looks like then. So basically, the state of Tennessee has instituted mandatory reporting for hospitals for when they have a child who is diagnosed with neonatal abstinence syndrome. So that data, anonymous data, goes to the state. And the state compiles that weekly. So we have nice data in real time. Okay? So we can use that data because we do know from a lot of the research that's been done that about 1/3 of the newborns with prenatal opioid exposure will develop neonatal abstinence syndrome, which is when the baby withdraws. Okay? So the NAS rates times about 3 will give us a rough estimate of the overall pregnancy opioid use. All right, so this is what it looks like. You can go to the tennessee.gov website and you can get weekly updates on NAS rates across the state and by region here. Okay, this one that I've dropped into this slide here is actually from the final week of 2017, but they have released data up now into March. But I wanted to give you an overall what kind of a yearly snapshot might look like. So they do a really good job of putting all this together. You get this nice thing that shows you the increase in cases. First thing I want to show you here. Okay, we had 1,015 NAS cases statewide in 2017. We had about 75,000 births, so we're looking at about a 1.3, 1.4% rate of neonatal abstinence syndrome. And the rate, that's double the national rate. All right, so if we use that 1/3 of those who use will have babies with NAS, we get more than 4% of Tennessee women using opioids during pregnancy. Pretty high rate. All right, now if you want to look here, almost half of the cases of NAS statewide come from the Northeast and Central East region. So a very small part, eastern part of the state accounts for almost half of the cases. So it's more of a problem here in the East. All right, and then about 2/3 of the women are on medication-assisted therapy, so it shows you it does lead to withdrawal in the newborns, and nearly 1/3 of them are misusing a prescription opioid. Okay, so if you have an interest, go visit the website. You can drill down and look at this by week. All right, so let's talk about some of the outcomes really briefly. So like any other substance abuse, prescription opioid misuse has significant consequences for most users. So this is kind of global. If you do work in substance abuse generally, the effects are pretty similar. Okay, so we have people who are using drugs, impairs judgment and thinking, obviously. So it's increasing accident rates, leading to a lot of negative consequences in terms of career performance and attainment. Obviously, it's going to impact your social relationships if you're using drugs, going to impact your quality of life and your ability to make money and live well. And we also see increased rates of disease and death. So I'm not going to go into these in great detail, but just so you kind of have a sense of what the life looks like for somebody who's using these opioids. Okay. What I do want to talk about a little bit, though, is these special populations. So adolescents and pregnant women in particular have particular challenges in terms of the outcomes associated with their drug use. Okay, so with adolescents, the thing that we're most concerned about is the fact that their brain is still developing. Okay? So their brain is still forming connections, different things are happening in terms of the development of both their brain and the neurochemical system. And when you add some sort of insult when development is occurring, you tend to see negative effects. And so if an adolescent uses drugs, those affect the brain development and impact things like the structure of the brain, the function of the brain, and the neurotransmitters. And it affects a lot of domains. There's been a lot of research on how it affects different domains of the brain, or different regions of the brain. Okay. Now, the research that's been done has shown that some of these alterations resolve after drug discontinuation. So if you had to have an adolescent, they go into treatment, some of these things resolve, but some of them do not. Some of them seem to be permanent. Okay, in terms of looking at developmental implications of drug use, marijuana has been the most studied. There's a lot of studies out there showing the harms of using marijuana while the brain is still developing. There's also a lot of research on alcohol and how that affects the brain. We know really a lot less about the impact of opioids and how that impacts the brain and development in adolescents. Okay, so the studies that are out there, we certainly need more, but this is a summary of what some of these studies have shown, that nearly a dozen brain regions are impacted. Brain connectivity is decreased. Connectivity is very important for higher level functioning. Okay, multiple neurotransmitters affected, serotonin, dopamine, all impacted in terms of how everything comes together. We have preliminary evidence of particular outcomes, cognitive planning and decision making. So adolescents who've abused opioids, the one consistent thing we see in the research is they have difficulty with planning and decision making. Okay, the other domain that's impacted has to do with attention. So these adolescents very often have a hard time attending for long periods of time. They tend to be very impulsive. They actually look a lot like kids with ADHD. And then issues with emotional regulation, tending to have difficulty in stressful times, dealing with negative emotions, being able to control their emotions. Okay? Many of these effects, as I said, persist long after drug use has ceased, and the effects are even seen with treatment drugs. So if they're taking buprenorphine for treatment, we still see some of these effects. All right, so I always put a slide like this in every talk I give when I'm talking about effects, kind of my caveat slide. So just because a particular person uses drugs, was exposed to drugs, does not mean they will have all of these effects. Okay? What we're really talking about here is an increased risk. Okay, so an adolescent who uses opioids is at increased risk for difficulty with thinking and planning, difficulty with attention, difficulty with emotional control. Okay, every child is not going to be impacted, and they're going to be impacted to different degrees. Okay, so it's an increased risk that we talk about. And the effect is impacted by a lot of factors. So obviously there's going to be dose response, so the more drug you use, the greater the impact is probably going to be, especially if it's during a critical period of development. Okay, genetics, there's emerging evidence about how your genetics impact whether or not you are going to be impacted and to what degree by drug use. Okay. Other comorbidities, so a child who already has ADHD starts using these drugs, imagine what they look like after that. Okay, so they're much more susceptible. Okay, other drug use, these tend not to be in isolation. So an adolescent who's using opioids might be smoking cigarettes, might be using marijuana, all of that is going to impact the effects that are seen. Social environmental risks. A lot of the drug users are not your typical drug users as we used to see. We used to see more marginalized populations using drugs. Now with prescription opioids, it's more of a middle class problem. And so it's been interesting to kind of see whether or not social environmental risks or even protective factors, how that might influence the impact. Okay? Somebody in active withdrawal obviously is going to have a lot more difficulty thinking and planning and have trouble with emotions. And then if they had prenatal drug exposure. All right, so let me talk about that prenatal exposure in pregnant women. All right, so can anybody tell me some of the negative pregnancy outcomes when a woman uses opioids? So what happens? What are the consequences for that pregnancy? In addition to neonatal abstinence syndrome, obviously. Guesses?
Decreased blood flow to the baby.
Okay, decreased blood flow to the baby, so what can that lead to then?
You can
Okay, so growth restriction, okay. All right, so yes, we do see a lot of growth restriction. Anything else? Yes, no? All right, everybody's really quiet. I'll put them up. All right, so all of these things have decent evidence as being impacted by opioid use during pregnancy. Okay, so the growth is right there. Second, we see pregnancy loss. We see issues with the placenta in terms of providing optimal nutrition, preeclampsia, so hypertensive type problems, premature rupture of membranes, and preterm delivery. Nice little graphic here that shows all the potential complications for your pregnancy when you use opioids. All right, so in addition to those complications of pregnancy, there are also long-term problems that can occur for the fetus and the child. Okay, most of illicit and prescription drugs of abuse readily cross the placenta, so they're getting into the baby's system and affecting fetal development. The brain, the neurotransmitters, again, just like we saw with adolescents, there's also rapid growth of those during gestation. Marijuana and cocaine have been very well studied. There's emerging evidence for opioids, but we need more research. One of the challenges in doing this research is polydrug exposure. So it's really hard to say opioid use caused this problem, caused this child to have behavior problems, when mom also smoked tobacco, smoked marijuana, and maybe dabbled in cocaine while she was pregnant. So how do we figure out which drug is causing which outcome? So that's a real challenge in this research. And then, of course, we have the confounding issue of socio-environmental factors. We know child development is very much impacted by the home in which a child grows up. If you have a drug-using family, okay, that environment's going to be very different and probably not conducive to development. All right, I'm going to mention really quickly here 2 studies that have looked at prenatal opioid exposure and long-term outcomes. The first comes out of Norway, and it compared children prenatally exposed to prescription opioids to children who did not have that exposure, controlled for background factors. And they found that the exposed children had significantly lower global IQ. And this study to me is astounding because I have never seen a study that has shown that big of an IQ effect for a developmental exposure. Okay, 20 points is huge. Right? Lower freedom from distractibility, so getting into that attention issue again. They had double the rates of attention problems, higher levels of social problems, and higher levels of conduct problems. So then imagine how these children are performing in school with all of these problems. Okay, the second study actually looks specifically at school outcomes, and this comes out of Australia. And I love this study because they actually use these standardized test scores, much like what we have here when children take the TCAP. They have a national test in Australia that is given to grades 3, 5, and 7, and they found that the children who were exposed to opioids prenatally had significantly lower scores in all the domains, math, reading, writing, so it wasn't specific to any type of cognitive issue, kind of global. And they found them up to 70 points lower on a 1,000-point scale, so pretty big deficit. Okay? Important, the results were consistent across all 3 grade levels, so it's not like they went away, where we've seen some of the studies we've done with cocaine and alcohol, we found that some of these kids kind of catch up. Not so with the opioids, it appears. Okay. Differences actually increased from grade 3 to grade 7, and look at the last bullet point here. At grade 7, the exposed group scored significantly lower on all domains than the grade 5 national average. So they were 2 years behind in terms of academic performance. Almost half of them didn't meet minimum standards on at least one domain. So these are big, big effects. There are studies that are just beginning here in the United States to start to look at what this means in an American population. All right, so to wrap up here, just a few bullet points here to summarize what I've said. Prescription opioid misuse is common in the U.S. You've certainly seen that. We exceed the rates in all other countries, unfortunately, and it's increased dramatically in the last 15 years. So this is a newer problem. Highest rates are seen in young adults, with use in adolescents decreasing recently. But the overdose death rates are actually highest in the older adult population. Okay, Tennessee, along with the rest of southern and central Appalachia, experiences really high rates of opioid prescribing and opioid overdose deaths. Opioid use among pregnant women is unfortunately at historic levels, resulting in high levels of neonatal abstinence syndrome. We see this problem particularly in eastern Tennessee. Okay, due to the developing brains, adolescents are at high risk for problems related to opioid misuse, so that's certainly a population that we want to target for intervention. Pregnant women, also another population to target for intervention. We've got emerging evidence about the long-term implications for prenatal opioid exposure. And as I've said multiple times throughout here, we really need more research so that we can effectively inform both prevention and intervention efforts. All right, and with that, I would be happy to take questions. Yes, ma'am.
So is there any understanding of why the actual deaths are higher in the older age group? Is that partly that they've had more experience, maybe pushing the limits, or is it they have more money? Perhaps they might think they have jobs, they can afford it more.
Yeah, the preliminary evidence is out there, and it's still very preliminary, suggests that they are using more. So, as you said, they can probably afford it. They're more likely to use more. There's also some evidence about some vulnerability because of their own potential health problems. Okay, so when we move into the 50s, we might have some chronic health problems that are compounding the issue. You know, a death usually occurs because the respiratory system shuts down. So if you've got somebody, oftentimes opioid users are smokers, they might have been smoking for 20 years, they've got some compromised lung functioning. So there's some research out there, but it's certainly not totally clear. Yes?
So I really was interested in your data in those last couple of slides about the studies in Norway and Australia.
Uh-huh.
So I just wanted to clarify, this was based on use and not the presence of NAS.
Correct.
And was there any differentiation between the ones that were given, like medication assistance treatment versus illegal opioids?
Right. So the Norway study was actually all women on MAT. Now, many of them also used other opioids, but they were all on MAT. And when they compared the women who were on MAT with the women who were MAT plus other opioids, the effects were worse.
Say that again.
When they compared the women who were just on MAT with the women who were on MAT plus they supplemented with other opioids, the effects for the children were worse.
In the second group?
Yes, in the second group, yeah. So, yeah.
But the women with MAT were also, the babies had learning impairment shown.
Yes, absolutely, they did. And you mentioned a good point there about the NAS. These were not necessarily babies who developed NAS, and that's one of the big questions right now is, do you have to have NAS to have these developmental outcomes? And the answer is appearing to be no. Dr. Goodkin.
That was a great talk that showed a lot of data on the epidemiology of use. I wonder if you have access to data about the epidemiology of treatment for opioid use disorder, particularly breaking it down by opioid substitution versus opioid antagonists, behavioral treatments and combinations. And one of the reasons I ask is I suspect that there's a significant mismatch if you look at trends for access to treatment by where the prevalence of prescribed opioid use disorder is, especially in rural regions.
Right, yeah, no, very true. The data that I have seen have suggested that where treatment is not matched up at all with where the big need is. So we have those more in larger population centers, areas with higher socioeconomic level, but we don't have a lot of treatment options for rural people. There is an ongoing study right now that's crunching some of the data, the Medicaid data nationwide and private insurance as well, looking at substance use disorder treatment and how that aligns not only with region but with the abuse, death rates. So I'd be interested to see when that comes out later this year. Yes, sir.
You know, I'm very interested in your comment about the joint and their perception that they should make pain the fifth vital sign.
Mm-hmm.
I'd be interested in an opinion. Many of us that were in organized psychiatry leadership at the time were very, very concerned because the proper choice that they could have made was absence of pain as a fifth vital sign. They got it completely 180 degrees out of joint.
Right.
And, you know, at first that was poo-pooed off as a insignificant concern because everybody was saying, oh, who's paying attention to that? The difficulty with it was the way they wrote it. It empowered both substance abuse and somatization disorder and completely ignored the psychology of the problem here,
Right.
which is that folks that are intoxicated on opiates are chasing dissociations.
Mm-hmm.
And then it appeared at first that they were doing this on a platform of compassion, And then when they dropped it, it was like they also dropped their platform of compassion.
Exactly.
So now, the situation is, even for people in non-oncologic situations that really do have serious issues, things have become incredibly difficult. Whereas we haven't really done that much to change the epidemiology of the circumstances. And a lot of it comes from the fact that the joint should never have been empowered to do something as important as making a vital sign.
Right.
You know, if pulse is 0, it's not a sign of health. So pain isn't a sign of health. Absence of pain is a sign of health.
Correct.
And they really misconstrued this and got people in a wrong-minded perspective on what to do with these issues.
No, I agree completely. And it's not just semantics when you say pain versus absence of pain. So, you know, by saying pain is a problem, that makes it a medical condition that needs to be treated instead of looking at what is the root cause of the pain and not just treating the symptoms. Like we do with most other diseases, we look at root cause, but unfortunately that led to this whole treatment and then this whole problem, as you see. And I agree totally that this issue of having difficulty getting pain medications, you know, I look just at our VA up the street, you know, that cut off all the chronic pain patients off their narcotics, in a sense trying to decrease, you know, stem the tide here, but now you've got a whole group of people that, where's the compassion for those people that need something? So, yeah,
I
good point.
probably should say I'm very involved in that. I'm chief
Okay.
psychiatrist.
And I'm not dinging the VA, but I know that's,
But I'm very sensitive to this issue.
yeah, and I think it's hard. I mean, there was no good solution. That was the one that they tried, and it worked in some of the ways that it was intended, but certainly had some unintended consequences as well. Mary?
Do you know if the governing bodies like ACOG, the American Council for OBGYN, are aware of this data about the damage of even medication-assisted treatment, because they recommend formally treatment during pregnancy with
MAT,
those drugs.
right. They know. I was at the Society for Maternal Fetal Medicine meeting back in January, and there was a 3-hour session that actually involved a debate among experts in the field, looking at putting women on MAT, which is certainly regarded as better than them being on street drugs of unknown amount and everything else. But the issue there was, do we maintain them on that, or do we try to taper them off? And there's ACOG right now is recommending maintenance, no tapering. But the data are really starting to show that you can safely taper. And so I think we're going to swing around in another few years, but right now the recommendation is that. And they recognize that it leads to NAS, but we still view NAS as a transient condition. You know, it's temporary, it's going to go away. So it's costly, it's difficult to deal with, but in theory doesn't cause long-term, at least the NAS doesn't cause long-term problems. Dr. Shah, yes.
Great talk, Beth. I think a couple of points. A, there are evidence coming back that yes, you don't have to keep the women or MHE during the pregnancy. You can taper them off, and we have a local data from Knoxville, you know very well. The other most important thing, I think it's coming nationally, where the state where they have legalized marijuana, they show decrease in opioid use. So A, we seen the THC long term is not that bad considering what you have seen this thing. So here I think it's going to come what is the lesser of evil up here, because when you have the opioid and when the long term data, even though it's a different country with a different geography, in Norway and Australia where they showed lower 3rd, 5th and 7th grade, there are still issues that we know is persistent, and considering how we have our gun laws and all that, and if you take into account what's going to happen in next 2 decades, I think it's very frightening.
Yeah, oh, absolutely. And the marijuana is a good point. So I have a joint appointment in Colorado this year where marijuana is legal. And it's been interesting to see the data out of the NICUs. We see decreasing rates of NAS. And so what that means long term, I'm not saying marijuana is safe during pregnancy, but it is safer than narcotics with all the data that we have so far. Yes, ma'am.
I was wondering about the Norway and the Australia studies too. Did they compare them to babies who had not been affected?
Yes.
And did they look at ongoing parental substance use in the homes?
Yes, so they controlled for substance use going on in the environment still, and they had a control group of children who were unexposed either prenatally or postnatally.
Okay.
Yes.
So, because those not 20 is like institutionalized, you know, the devastating.
The IQ?
The IQ.
Yeah.
That's, I mean, that's phenomenal.
It's huge. Now, the Norway study is small. It's about 200 people, so it's certainly preliminary, but I mean, that grabs you when you look at
Yeah.
that study, absolutely. Did I see someone else? Yeah.
So in that study, were they looking at, I mean, there may not be enough data out there, was it based on what time frame in pregnancy, so first trimester, second trimester, all the way through?
Right. So neither of those studies looked at that specifically. There are a couple studies out there that are looking at outcomes in 2- and 3-year-olds, so they're better controlled newer studies that are out there. And they're finding that the timing is not super critical. Certainly the timing is important for NAS. We know that later exposure, obviously the baby's exposed, is going to withdraw when it's born. But in terms of the developmental effects, we see effects even with first trimester exposure that they then quit. So it really has to do more with critical fetal developmental periods. Anyone over here have a question? I haven't looked over here. Okay. Anything else? Yes, Dr.
That's going back to those graphs of decreasing adolescent use for opiates. There was a really strong inflection point.
Yes.
Any idea what?
No, some of it was how the questions were asked and the change in how they asked the questions. So they went from asking about prescription pain medication to actually listing names.
But this was after that.
Oh, you're talking about the decrease.
Yeah, because there was a few years where it was level,
Level.
and then all of a sudden
It dropped.
started to drop. And what year was that? I couldn't.
Yeah, it was about 2014. 2013, 2014. So, you know, we've done a decent job in the last 5-6 years of getting into the schools and really talking about this issue, so maybe that's having an effect. I'm not sure. And maybe as the news coverage about the deaths has increased, you know, you see a lot now about opioid overdose deaths, you know, maybe that's hitting home for some of these people.
It would be interesting to know because it would be significant for prevention efforts.
Absolutely. So I know there is a study ongoing looking at why. At University of Michigan who did that survey, they're looking at the why right now. But I don't have any results from that yet. Okay, anything else?
I find it shocking that these doctors are actually prescribing opioids to pregnant women. To me, that is so unethical. It should be illegal, let alone unethical.
Well, I think, you know, there are medical uses for these drugs, and I think that when you have pregnancy, you've really got to look at the risk-benefit ratio, and they're making a determination that, at least for a short-term time, that the benefits outweigh the risks. Whether or not they have enough information to truly make that decision in terms of looking at the longer-term outcomes kind of remains to be seen. Anything else? All right, well, thank you very much.